Good afternoon. My name is Charlotte Haberacker. I'm President and CEO of Lutheran Services in America. It's wonderful to see everybody here today. Welcome to our Strength and Service series today. And as you know, Lutheran Services in America has been holding these series as a way to really provide expertise and outside thinking that's laser focused on examining and tracking unintended consequences and uncertainty in today's climate. I'm delighted to introduce Andy Edeburn, who is a principal with Premier Consulting and has more than 20 years of healthcare experience. His expertise is particularly in acute, primary, post-acute, and senior care services. And he's a nationally recognized expert in aging services and post-acute care. Today, he's going to give us an overview of current market trends affecting senior services and offer some ideas and methods for senior service providers to think about the future. Please join me in welcoming Andy.
Thanks, Charlotte. Good afternoon, everyone. Thanks for taking the time to join us. I'd make a joking comment about welcome to day 366 of Groundhog Day, but that would probably be inappropriate. Rather, I'm going to say this is the 1-year anniversary of the last time I was on an airplane. And in 24 years, that's a first for me. So, but to be honest, it's really not a bad thing at all. To Charlotte's point, we want to spend a little bit of time today talking with you about this topic I've characterized as reading the tea leaves, trying to really understand fortune telling in a fairly uncertain time for aging services and senior care organizations across the country. It's an apocryphal statement that, you know, may you live in interesting times, but the reality is that this is a pretty interesting time for provider organizations across the healthcare continuum, from acute organizations to primary care provider organizations to community-based health organizations. The last year has seen some phenomenal and amazing changes and adaptations to how our world works and how our world operates. And as we look to the future and starting to see lights at the end of the tunnel about what the future might look like for provider organizations across the healthcare continuum and across the community provider space, it really is important to think about where are we going to land in that new landscape, because things are not going to be the same. COVID really, at one level, and at Premier, we talk about silver linings associated with COVID. What are the good things that ultimately come out of this? And there are a lot of good things that ultimately are going to change in healthcare delivery and in service delivery as a result of COVID, but there are also a lot of fundamental changes that are going to alter the bedrock of some of these entities in the healthcare organization. And we, in senior services in particular, are not going to be immune from those changes. And so as we start thinking about the future, it's really, really important to ask some real key questions about your organization and about directionally where you've been and where you're going, and does that direction still make sense into the future? Because the way in which organizations, and what I mean by that is healthcare organizations, payers, others that we engage with and depend on for business, how they are going to go about conducting their business and how they are going to turn and rely to us, look to us as partners, is already undergone some pretty dramatic shifts. And there are a lot of people who are saying, gee, I hope it's all going to go back to normal. We talk about things trying to get back to normal, but the reality is that normal is going to be a very different thing. I hate the phrase the new normal, because there never really is a construct that is a normal. It's safer to say that going into the future, things are going to be different. And depending where you are as a size of an organization, the scope of your organization, the types of lines of business you have and operate, is really an important consideration about how you're going to land ultimately in the new landscape. So I want to spend a little bit of time talking about those things today. There are 3 big chunks of this presentation today. We're going to talk a little bit about the backdrop. Some of these are things most of you are going to go, yeah, Andy, we know that. But they're really central in understanding foundationally why we've gotten to this point and why it is so crucial that we figure out how to change and adapt. Then I want to talk a little bit about the direct impacts from COVID. What does that mean for us? And then more importantly, what do we need to be doing about these things? How do we look forward? How should we be thinking about our organizations in that context? So, you know, the reality is that I think for a lot of people, and if someone had told me in my 30s, by the time you get to be 50, you'll only sleep 5 hours a night, I would think that was absolutely crazy, because if there's one thing I know I am exceptionally good at, it is sleeping. And I have discovered in the last 5 years that I am not good at sleeping anymore. It's a terrible thing, to be honest. And there are a lot of things that keep me up at night. And for a lot of us who are operators, who are leaders in organizations, you really have to beg the question, question, what are the things that are on our mind? What worry us? Well, no question, COVID is a huge part of that. Every day, whether you're thinking about how it's going to impact me operationally, how does it impact the people I serve? How does it impact my staff? How does that impact the long-term mission of my organization? Those things are all in play. We're dealing with constantly shifting clinical expectations, the regulatory merry-go-round that is state and in particular federal environment in the last 10 to 12 months. Will my volumes ever come back? If you're an organization who's predominantly driven in the healthcare space, or say you've got a big component of your business in the nursing home world, will your volumes come back? It's a great question. How do we stay relevant and essential in our markets going into the future? How does my mission continue to matter as an organization into the future? What are hospitals and other payer organizations thinking about in that space? And what does this ultimately all mean for us? What's the confluence of all these things coming together? And is there a way forward? Is there a way out? So as we go through these things, by all means, I know there's probably going to be questions. So in the chat box in the bottom of the Zoom, as you have a question, please put the question in there. We're reserving some time at the end to talk about questions rather than take them as we go. So if you have a question, by all means, please throw it in the chat box and we'll get to it. Let's talk about four of the big fundamental things that are behind really the challenges that are impacting us, really quite frankly, from a payment perspective. Because when somebody says to you always, it's the principle of the thing that matters, it's not about the money. The reality is so much of what we're dealing with right now is about money, and money as it relates to healthcare, and money as it relates to major demographic and socioeconomic shift in our country. So we don't need to spend a lot of time talking about the nature of the aging population. 10,000 people a day hit the Medicare rolls, 10,000 people roughly a day hit Social Security. We're an aging nation, and that immense growth of an aging population on one side represents tremendous opportunity for senior service provider organizations, but it also imperils the payment systems that drive a lot of that behavior. And we're spending a lot of money on healthcare, more and more money. We have a reactive-based healthcare model of service in our country, and we pay on a fee-for-service nature. We pay for volume. And so the idea of thinking about how you move to a preventative model of care, how you manage healthcare spend, that's a central driving tenet in everyone's thinking. We know that it is not fiscally sustainable for us as a nation to continue on this arc, and at the same time, the relative health of our population across the board, really from birth to age 100, is declining overall. The presence or the prevalence of chronic disease is a profound issue, and chronic disease drives almost 99% of Medicare-related costs. So if you figure out how to manage chronic disease, you figure ultimately how to contain costs. And we have to do that if we're going to address the sheer number of people who are impacting the system. In the last 10 years, the way in which we have paid for the bulk of services that serve elders, and that's Medicare, okay? The way in which Medicare services are paid for has shifted 180 degrees in our country. So in 2010, 3 out of 4 Medicare beneficiaries, Part A Medicare beneficiaries, were paid for under what we call a fee-for-service model. And a small percentage of them, about 24%, were paid under Medicare Advantage or managed Medicare replacement plans. Come to 2018, 2019, 2020, those numbers have changed dramatically. Less than half of Medicare beneficiaries are paid on a fee-for-service model. Nearly 35% of them are now paid under Medicare Advantage. So Medicare Advantage has grown more than 50% in the last 10 years. And we've now had the introduction of accountable care organizations, these entities that are designed to manage and control cost of spending as associated with accountable care. And in that environment, the nature in which how ultimately we're getting paid has changed dramatically if you're in particular a person who receives payment under Part A. So legacy nursing home organizations, nursing home components of provider organizations, all of that payment system has dramatically shifted. Payment more and more is under risk going into the future. And so what was once the lion's share of the best payment we could get in this environment has dramatically flipped in favor of payment or services that is heavily managed by somebody else, a Medicare Advantage plan, a payer, an accountable care organization. That trend is only going to accelerate after COVID. At the same time, there is tremendous impact on the Medicare Trust Fund. The last formal actuarial report of the Part A Trust Fund said it would run out sometime 2027. Now they're saying, in reality, as a result of COVID and the spending infusions to address the national emergency in the last year, that number is more like 2023, 2024 potentially. So we're running out of money even faster than we thought we were going to, and that is creating all sorts of other issues across the board. There are 5 big big drivers that people in the healthcare world are facing as a result of COVID. One is the financial stability of provider organizations and also partners in that space, and how do we really create a more stable financial platform. One of the most interesting lessons in history comes from the United Kingdom. After World War II, the government in the UK looked at the sheer amount of dollars they had lent to the healthcare industry, and they figured out it was somewhere between 90 and 95% of what hospitals that were predominantly privately or community held in the UK, most of that debt was held by the government in the UK, and they decided at that point, we practically own it anyway, and they nationalized it. And we're nowhere near that number, but the federal government and to a lesser degree, state governments have infused via federal dollars a tremendous amount of money into healthcare, and that's impacted the Medicare Trust Fund. It's created questions about stability. It's accelerated federal and state deficits. And so in this environment, health plans and disruptors are looking at this as the sort of crisis opportunity to advance new models, to create new thinking, to really drive change and disruption at an accelerated pace around healthcare delivery. At the same time, there's been a huge shift in consumer thinking and consumer preferences. If you've talked to patients, if you've talked to patient family members, they don't want to go to a nursing home right now because most of the news we've had in the news in the last 10 to 12 months has not been the best of news about the nursing home industry. A lot of it is unfortunate because it's people who don't understand how the industry operates. They don't understand the nature of why COVID-19 is terrifying and scary to a nursing home organization. But the reality is we've suffered through bad press. That shifting consumer movement and a desire on the part of policyholders and stakeholders and payer organizations to drive more care into the home is kind of that perfect storm that's come together to push more care into that space. So there's tremendous emphasis on telehealth, on virtual monitoring, about shifting as much care into the home as possible in the same way that we're all working from home and we're shopping from home and we're living at home. All of the mindset that has existed historically has said, you can't do that at home. You can't do that at home. Oh, we've learned tremendously, all of us. There's a lot of stuff we can do at home, and healthcare is not immune from that in any way. And at the same time, you've got a large share of the workforce that's still unemployed. There's a tremendous increase in uncompensated care, and there's a shift in payer mix around that space. And unfortunately, all of these five things really come back to the first one, which is money, the financial impact and cost of delivering healthcare in our system. So what are people looking for? We're back to looking for the construct of the triple aim. What's the best care in the best location at the best price to get the best outcome for patients? And right now, the driving thought pattern around that is more care and service into the home. We're going to run out of money if we continue to go down the road we have. So there is tremendous urgency about figuring out how we potentially change this thinking. By law, if the Medicare Part A trust fund runs out of money, there are really only two things you can do. One, you can start rationing benefits, which will not be remotely popular with any beneficiary who's worked their career with the expectation that's Medicare, and by default, Medicaid is going to be there for them. Or you raise the taxes that are processed against payroll that pay for Medicare. So you cut benefits by 45%, or you essentially increase payroll taxes from 1.9% to essentially what is 9%, 5x, it's 5x essentially, to get to the point where you can afford to pay for Medicare going to the future. So we can increase funding, raise Medicare taxes, or we can alter the available benefits, which is to reduce the benefits, neither of which are politically palatable in any way, shape, or form for anyone in Washington, D.C. Or we can do the third thing, and it's the most likely scenario. We can adjust the payment model, which means we move away from fee-for-service thinking. We push more risk down to providers. We tie payment for quality. So the last 10 years, everything myself and others in this world who work with elder care and aging services organizations have been talking about, the crisis and inflection point is upon us at this point. More than half of our payment moving forward is going to be put at risk. And inevitably, if we move to site-neutral payment for post-acute care, which is a strong consideration given everything else that's going on, we're going to move even faster into risk-based payment. So it's all about altering the payment model. There are three ways you can go about doing that. One's total cost of care models. That's accountable care organizations. That's the evolutionary construct of ACOs that we now call direct care contracting or direct contracting entities. You can move into enhancing more care into the primary care space. So that's something we call CPC Plus or primary care first. These are all models that CMS has really essentially pushed down into the acute care and primary care provider space. And they're a big fan of episodic payment models, which is bundled payment. And the bundled payment one in particular is very, very important and to pay attention to, because if you go all the way back to the ACA, almost 11 years ago now, one of the things that was key in the ACA was a national mandate for bundled payment, for episodic payment. And most of the bundled payment in our country in the last 10 years has been voluntary, with the exception of the Comprehensive Care for Joint Replacement, or the CJR initiative that evolved in 2015, 2016. Most of bundled payment has been voluntary. CMMI, the Center for Medicaid and Medicare Innovation, which is really the driving force behind bundled payment, has made a major shift in bundled payment in the last 10 months in our country. And they've moved people away from individual procedures or episodes in favor of what we call clinical episode service line groupings. So if I'm a hospital and I voluntarily choose to participate in bundled payment, and I go at risk for all the services in the hospital and in post-acute care and thereafter for 90 days, because pretty much all episodes in bundled payment are 90-day episodes, okay? You were able to do that for one diagnosis. I could just do it for hip replacements. I could just do it for hip fractures. I could just do it for a particular GI procedure. Now they've lumped them together and say, you have to do 8 procedures all grouped in cardiac care. You have to do 9 procedures grouped in orthopedics. So they're consolidating it in such a way that you can't pick and choose. They're making it a little tougher. And this is essentially an interim step for them to move all of the volunteer bundle participants into this model before they move the nation into a mandatory nationwide bundled payment program that's likely going to happen sometime in 2023 or potentially 2024. Why is that going to happen? Because we're running out of money, and bundled payment is the only actuarially sound way of predicting that you can actually save money under Medicare. About 25% of the hospitals, somewhere between 800 and 900 hospitals in the country, participate voluntarily in bundled payment. That's another 26 to 2,700 hospitals who haven't done a thing in bundled payment. They've stayed away from it as long as possible. Their hand is going to be forced into that environment very, very quickly. Somewhere between 25 and 35% of the spend in a bundle, on average, is in post-acute care. And if you're a hospital and you're suddenly thrust into an environment where I'm at risk for 35% of the cost in an environment I don't know, which is post-acute care, they are going to run like crazy people into the night with their hair on fire. And they are going to figure out the cheapest and most cost-effective way to do that. And I can tell you, and Donna Sella, who many of you know, who I've worked with some of you over the last few years, and I pretty much refer to 2020 to 2023 as the decade of home health, because all of the care, in as much as possible, is going to move into the home environment because it's less expensive, because it's where people ultimately want to get treated. At the same time, and I alluded to this, there is the continuing discussion that's going on around site-neutral payment, which is essentially an episodic-based payment model or a DRG-based payment model for post-acute care providers. So instead of getting per diem payment in the nursing home environment, we're talking about getting a fixed payment amount, an episodic payment amount for a stay in the nursing home environment. Acute rehab, long-term acute care hospitals, home health, they already get paid episodically. It's only a matter of time before this model shifts. There have been a number of studies done. A lot of people have advocated that we should have moved to site-neutral payment already this year. It's likely to happen in the next 2 to 3 to 4 years. So we're talking about a national bundle mandate. We're talking about shifts in site-neutral payment. We're talking about growth in Medicare Advantage. Virtually every qualified or valuable payment stream that we use in the post-acute space to one degree or another is likely to undergo some degree of change or some degree of threat in the next 2 years. And in this environment, and I don't mean to be a doomsday sayer, but in this environment, not everyone is going to survive. National occupancy in nursing homes prior to the pandemic was about 82%. Nationally, occupancy right now in nursing homes is about 70%. If we get back to 80%, I'll be shocked. We're probably going to land somewhere in the 74 to 75% land. That doesn't mean people don't need service. It means people are going to get service somewhere else. And likely that service is going to be delivered in their home via some provider who's positioned to be in that space. We are living in the cusp of a perfect storm front right now, and how it plays out in the next 18 to 24 to 36 months is going to be a fascinating process to watch. And so for organizations need to be mindful, and I would say nimble in this space if you really want to figure out how to be successful and how to survive long-term in this environment. So in the near term, with regard to COVID, if we think about that's out there as an unknown for us in the future, what are we dealing with in the short term? What are the things we can do to adapt and adjust in a post-COVID environment that help us get through the next few months or even the next couple of years, but also position us appropriately to hopefully be successful into a bit of that unknown? There are always some things we can know are safe bets. They're the right things to do, regardless of what ultimately is going to happen with the payment system. When I started talking to people about the ACA and value-based payment 10 or 12 years ago, and I was talking with another colleague of mine just yesterday who I was doing that work with years and years ago, we talked about something we used to always say to people, and it's this, I'll say it again because I think it's so important. If you focus on nothing else but quality, you are doing the right thing any day of the week. Because if you can deliver quality outcomes, whether it's in a nursing home, in assisted living, in community-based care, in a home, if you can differentiate yourself on the basis of quality clinical care, you are creating the greatest foundation for you to be successful going into the future. If you migrate immediately to try and figure out how to do cost without addressing the quality, you will not succeed. You have to focus on quality. And that's important because the differential in quality between a lot of providers is not profound. It's not dramatic. It doesn't have to be dramatic. You simply have to be better than the pack, and ideally, you want to be in the top 3 or the top 5 in your market. Because time and time again, and I can say this over and over again, because 5 years ago, I went over to the dark side of hospital and health system and didn't spend as much time in the post-acute and senior services world. What hospitals and health systems and payers are looking for is low cost and high quality, and they are willing to make exceptions on the cost side in favor of quality. So you can be a low cost provider and think you're in a sweet spot, but if your quality is terrible, you're not. Focus on quality. That's the most central important thing to think about in a post-COVID landscape. So what happened in February, March, April, and May? Well, the data is pretty telling, and most of us who live as operators know this. We witnessed this happen firsthand. In March, the national pandemic hit, percentage of inpatient discharges, hospital volume elective procedures, fell off the face of the map. And because so much of what drives volume ultimately into the post-acute space is tied to hospital volume, guess what? Dominoes roll, snowballs roll downhill, dominoes fall over. We all got impacted by that. So you can see percentage change in volume and discharges to SNF, percentage change in volume and discharges to home health. March, April, May, they all tanked. It was terrifying. And for a lot of provider organizations, this trend hasn't really reversed. They're still operating at lower volumes. You're going to notice in June and July, and I haven't seen really good reliable data for August, September, and October just yet, but home health starts reversing the trend. So what do people want? Where do people want to go? They want to go home. Where do hospitals and health systems want to send people? They ultimately want to send them home. And there was a tremendous amount of waiver opportunities that CMS set forth in April and then again in June and just now in November to make it easier to manage and care for and be paid for care and services that are ultimately delivered in the home. One of the common questions I get all the time is, how long do you think these waivers are going to last? To be honest, some of them will end when the national emergency ends. Others, they're going to be here forever. Because quite frankly, what we've done, we've shifted the paradigm. The cheese has been moved, profoundly moved. Because telehealth, virtual health, in-home monitoring, in-home service, that's where people want to get served, and provider organizations have figured out we can do it effectively. We can do it cost effectively. We can do it from a quality perspective. So when you talk to hospitals and you talk to health systems and you talk to payers about what's your strategy right now, in particular in the post-acute space or in the elder care space, they will tell you anything we can do to get people home and keep them at home and manage at home, that's top priority in our list. So there's been this huge shift akin to what we saw happen with orthopedic patients in 2015 and 2016 that historically would all go to the nursing home that suddenly started going to home health. And more, a lot of patients who could potentially be managed in the SNF are now potentially moving even more so to home. It's not to say patients aren't going to keep coming to the nursing home. They are. They're just going to be, guess what? Profoundly medically complex. They're going to have complex clinical morbidities attached to them, and we have to develop capabilities to manage those types of patients. And it's not just because of COVID. The real value in doing that is long-term. If we think about site-neutral payment going down into the future, the opportunity spaces, there's a whole nother layer of complex institutional elders who have very complex medical needs, who need care and service in institutional post-acute settings that CMS isn't going to be willing to pay for in acute rehabs or LTACs. So that means the next likely place for those people to emerge from a service standpoint is in the skilled nursing facility environment, if you focus on quality and if you're clinically capable of managing that population. So it's not all doom. There's plenty of opportunity in the future, but you have to shift your paradigm about what you're doing. For organizations who are still very, very focused on rehab and orthopedics, you've missed the message in PDPM, which is to move you in the direction of clinically and medically complex management. I would also say for home health organizations, the degree of clinical intensity and patient severity that you need to be able to manage in the home, that's increasing as well. This extends all the way back up into the hospital space because in late November, CMS granted waiver authority for acute care hospitals to be paid under the acute care hospital payment system to provide hospital at home, to provide acute care hospital services in the home. And that's exactly what it sounds like. That's bringing the hospital into an individual's home. That waiver is probably going to stick around for quite some time. It's a model that's been around for nearly 20 years. Don and I and other Premier are working with about a dozen organizations across the country right now on hospital at home opportunities. And as people are starting to figure out how to deliver hospital at home, believe me, they are accelerating their thinking about how we can deliver post-acute and rehabilitative care in the home space as well. So that shifting degree of acuity step down that I talked about, patients who once went to the nursing home now go to home health, or people who once went to the nursing home can now in a lot of cases be managed in very aggressive and capable assisted living provider organizations. The folks who are in acute rehab, the folks who are in LTACs, they can be managed effectively in advanced skilled nursing facility organizations. Don and I were just talking last week with a group in New Jersey who wanted to talk about how do we build a super SNF, the SNF that's capable of doing vent weaning, the SNF that's capable of managing traumatic brain injury or spinal cord injury. So how are you elevating your clinical skill set? At the same time, if you're in the home and community-based or community-based services space, how am I either building skills to work in that space, or how am I co-opting or partnering with people who can really elevate my portfolio to help serve those individuals as well? Because the push is going to be into the home, into the home, into the home, into the home. So in the short term bets for most organizations, and this is really focused on SNF provider organizations because they're the ones really under the most threat, are really in three things. One, it's about if your elective volumes have dropped off and hospitals are not working with you like they did in the past, or they just don't have the volume back, and when the volume starts to come back, you want to be first in the list. It's about reaffirming your referral status, which is what am I doing to demonstrate that I'm a new and improved preferred provider in this space? How am I growing my capabilities as an organization to address this? And then the third thing is how am I outlining my paths to greater partnership? So I'll just touch on these very briefly. When it comes to reaffirming preferred provider status, it is really about having that leading edge clinical or programmatic capabilities to align with what hospitals and payers need the nursing home of the future to do. It is not about how do I continue to manage hips with modalities. It's about managing complex congestive heart failure, complex pulmonary and cardiac illness. It is being adept at things like emerging traumatic brain injury and spinal cord. It's about building centers of excellence around stroke. So some of these huge clinical opportunity areas that exist in hospitals that they're trying to figure out how do I manage more effectively and in a lower cost setting, they're starting to look at super SNF or really advanced SNF capability organizations as a potential solution for that. Second, it's demonstrated infection control management outcomes. The unfortunate thing about COVID is it hit at a point in time where a lot of us were still just really kind of evolving capabilities around infection control as a result of the mega rule in 2016. And so demonstrated outcomes around infection control. So years and years ago, I used to say to people, don't tell people what you can do, prove to people what you can do with outcomes. It's not about, oh, we have an infection control program. It is entirely about, we have an infection control program. Here's our outcomes. Here's our process improvement related to it. Here's how we've dealt ultimately with issues. So it's proving what you actually say you can do. And then third, the big thing is optimized use and capabilities around telemedicine, whether that's for primary care consults, whether that's for specialty care consults. How are you engaging primary care in that space, and how can you be an advanced and capable partner there? And then it's the basic things. It's no readmissions, it's high patient satisfaction, it's addressing clinical and quality improvement, and to a degree, it's cost of care lower in comparison to peers for comparable or better quality. On the clinical capability set, I think the single most important thing that I urge people to think about right now is standardizing care. And what that goes to is eliminating variation or opportunities for variation in care delivery. That's evidence-based driven care in the skilled nursing environment. So what are your protocols and pathways that support complex diagnoses in complex patients? What tools can you leverage from a bedside perspective to provide clinical decision support to staff in that environment to be successful? So it's raising the game of your nursing staff to manage clinically complex patients. That's aligned with enhanced medical management in that space. So how are you driving more and adept primary care resources, either in situ or virtual, we're back to telehealth, to improve coverage and engage directly in clinical oversight of patients. And then it's the other things. How are we understanding cost as it relates to this environment? How are we developing internal capacity to really address utilization management? How are we partnering with providers who are going to continue to press us for shorter lengths of stay? How can we move in that space? And how are we leveraging EHR and informatics to drive ultimately all of that thinking? But the key here is standardization governed by evidence-based pathways and clinical decision support. Finally, the third one, and I think most organizations over the course of my career have always said, yeah, partnership, that's good, Andy, that's kind of nice, that's important, it's touchy-feely. But the reality is now more than ever is the time to start thinking about how we partner, consolidate, and work together in different forms, because there's going to be a lot of transactional activity in this space. Hospice and home health sales have gone through the roof the last 2 or 3 years. If you're a seller right now of a home health organization, you can command a pretty healthy purchase price. If you are a seller of a nursing home right now or nursing home beds, you're going to be hard-pressed to find anybody who wants to buy them because the value of them has dropped dramatically. It's just not a product line people are interested in. And so in that environment, there's going to be potentially a lot of mergers and a lot of consolidations among standalone SNFs and SNF organizations. Ultimately, we're going to have fewer providers overall into the future. How many providers is anyone's guess, but I would tell you, when you look at occupancy in the 70 to 80% range, that's a pretty good indication of that's the demand or need for how many beds our country really needs. We have 15,255 nursing home organizations in our country right now. If you take 80% times 15,250, what you're going to end up with is roughly 3,200 less nursing homes in the country sometime in the next 3 to 5 years. So are people going to fall off the map? Potentially, yes. Is there going to be consolidation? Yes. At what pace it's going to happen? Hard to say, but given COVID, that pace is likely going to accelerate. So strength in numbers, people. How do we come together? How do we partner to do managed care contracting? How do we partner to create independent practice associations? How do we figure out how to share clinical integration strategies? What's been interesting to me in 15 years of doing this kind of work is that in the last 2 years alone, I have had more than a dozen phone calls from organizations who've come to me and said, you know what? And this is a hospital or a health system. We think we want to buy a nursing home. Those are conversations I haven't had in 15 years with anybody, because they're starting to think more and more about this is an essential part of our continuum, but we need more line of sight to control it for quality, for cost, whatever the ultimate issue may be. So there are potential emerging opportunities for joint ventures around what historically no one wanted to joint venture around, interest in joint venturing around skilled nursing facilities. So as you think about your own markets and potential partners, and that's an important consideration in strategic planning for you as an organization, are there potential joint venture relationships we could explore? Because the interest is, there's renewed interest in this space in particular. And to that, I say to people all the time, understanding what your collective value is, okay? And value can be defined a lot of different ways. It can be cost, it can be quality. It's not just the valuation of what your real estate or your business is worth. It's really a question of what can I do with this thing? In the partnership capital discussion is an important consideration in defining a future partnering strategy. And I'll talk a little bit more about that at the end of the presentation in the last couple of slides. So let's look down the road. Let's think about all the money we're spending in this space and the ample array of providers and the impact of a national emergency and how much of our healthcare has historically been tied to real estate or legacy models or legacy payment systems, and the fact that we're running out of money. We have a substantial national problem that extends into the elder care space as well. I'll be the first person to say Medicaid in this country as a payment vehicle for elder care services does not work. It just doesn't work. And managed care organizations who've gotten into the managed Medicaid space, and in particular the managed Medicaid long-term care space, have made some pretty profound changes in states around the country about how they engage in this space, how they manage use in this space, how they manage spend in this space. And if you're an organization who's got some background in that, you've had experience in it, you've learned about it, that's a great background to start with in understanding those changes. But there's no question the direction about more care into the community, more care into the services, more service into the community, into the home is the driving thought in this environment. Let's just look at the way Medicare Advantage, which is the second best payer we're going to get historically in the senior services environment. Let's just look for a moment at how they utilize the spaces a lot of times that we operate in. On average, they send more people to home than fee-for-service does any day of the week. And their use of things like home health or SNF is roughly 60 to 65% of what it would traditionally be in fee-for-service environment. And most of us who operate in this space, we know that. We know that without question. Now, look at the bottom two lines, which is where we talk about IRF, which is acute rehabilitation, and we look at LTAC, long-term acute care hospital. You're going to notice the acute rehabilitation is used by Medicare Advantage at 25% of what it is for fee-for-service environment. That doesn't mean there's 75% less people in MA who need those service. It just means they're going to get it somewhere else. And that somewhere else is potentially either home health or more than likely a skilled nursing facility. So in that environment, that's where some of those opportunities emerge. So again, we're back to clinical capabilities, medically capable management skills in the skilled nursing facility environment for complex patients. That's one of the tickets. And PDPM is designed specifically, the patient-driven payment model for SNF is designed specifically to address increasing complexity of medical patients in the skilled nursing environment. So how am I retooling my clinical engine, my clinical operational engine? Then let's talk briefly about the Chronic Care Act, which was passed almost 4 years ago at this point, which allowed for Medicare Advantage plans to pay for non-traditional, non-medical services. So that means social determinant related services. That means community-based services. That means chore-based services could be paid for via Medicare dollars as opposed to the traditional healthcare related services. Like if it was in a nursing home, if it was in a hospital, if it was in a doctor's office, Medicare would pay for it. Now Medicare Advantage can redesign their benefit models in such a way to provide for all sorts of services that you would consider non-traditional medical services to really affect care of their beneficiary population. So in Texas, United and Humana in Texas, their two biggest non-traditional, non-medical services, the first 2 years of doing this, were air conditioning and pest removal services. And you look at that and go, well, that's a little crazy. No, it's not, because if you're living in an environment free of pests, it's healthier and safer, and if you're addressing air conditioning, you're eliminating heat stroke and heat-related illnesses. So preventive and innovative thinking is key to the Medicare Advantage organizations right now in how they're caring for beneficiaries in a preventative measure. Because if I spend $800 to put an air conditioner in that beneficiary's house and it saves them 2 hospitalizations for a cost of $25,000, that is a savings to me as a Medicare Advantage organization. So people are thinking creatively about how they partner and work in this space. Other models are addressing transportation, they're addressing nutrition support, they're addressing some degree of in-home support or chore-based support services. So the challenge, unfortunately, is that a lot of these franchise-based, for-profit, in-home instead senior care, senior or comfort keepers, these types of franchise-based home care models or chore-based home delivery models are incredibly well positioned to engage and partner with Medicare Advantage organizations on a market-by-market basis to really provide these supports of services and supports into this space. So again, we've got now a federal payment system that can support in-home care, in-home supports, in-home services. So, like I said earlier, 2020 to 2030 is the decade of home health. Home health is of such profound interest to hospital and health system and payer organizations across the country because it is the rock upon which people are building their community-based strategy. Home health, its own payment system, it has its shortcomings, it has its challenges, but home health as a structure, home health as a chassis is a fascinating operational model upon which you can piggyback other types of services. Home health organizations are usually pretty adept at moving between episodic-based payment, which is the bread and butter of their work, to per diem payment models or other creative payment arrangements with payer organizations or community-based provider organizations. There is tremendous interest in hospital at home. People talk about SNF at home. They talk about advanced or complex home health home health management models. And because there is so much in-home tech you can apply into this environment, it is ripe and rich for really being able to leverage technologies into that space, whether they're virtual monitoring, whether they are two-way communication systems, emergency response systems, whatever those ultimately seem to be. The interest upon the part of payers and hospitals and health systems is anything that enhances or delivers more and more care ultimately into the home environment. So for organizations right now in this opportunity space, well, where does my opportunity lead? Well, it's like everything else. We tell people, follow the money. When Donna and I and other members of my team work with people across the country and we start talking to them about care management or care coordination models or understanding how to affect better outcomes for beneficiaries or patients in the home, the first question we go to is, what do your contracts say? What are you going to get paid for? Where's the opportunity for you to get rewarded on the basis of quality and other outcomes? Really, what's in the money relationship that you can leverage to get better outcomes, to get better payment. And for the most part, that means better engagement with payers, better engagement with value-based entities, and to a lesser degree, engagement with government resources who drive a lot of that money. In urban and dense environments, there's a lot more payer opportunity. In rural environments, it's a bit more challenging because there's not as much density. Some states across the country are fairly advanced in managed care thinking. Minnesota and Florida, by way of comparison, have huge penetrations of Medicare Advantage, long-standing footprints in managed care, long history and track records with value-based relationships at the hospital and the health system, the community-based provider organization. Well, they'll create payment streams tied to outcomes if you can create a model that delivers value for them and their beneficiaries. Other states aren't as advanced around the country. So there is no, one of my all-time favorite questions, what's the best, always going to win strategy for my organization? It depends. It depends on your market. It depends on you as the organization. There is no magic silver bullet in here. That said, I would say there are three big things that we see organizations do across the country, particularly in the elder care and the senior services space, that are moving in the direction of opportunity, that have had some traction, that really create a space for elder care organizations, senior service and community-based organizations to really be successful in, okay? The first one is physician strategies, which is anytime you want to really get more into population health in some form or another, you likely have to align with in some form a physician organization. And the reason for that is most of the payment systems, whether it's federal, whether it's a private payer, whether it's Medicare Advantage, whatever, they look and think in terms of lives. How many lives can you manage? And lives are attributed to the person who provides most of the care for that live, and that is a physician, typically a primary care physician. So if you want to figure out stepwise progression into population health or talking more risk or enhancing your capabilities, how do you align with physicians? So seeking strategic partnerships to advance primary care into your CCRC, into your community, into your other community-based services offering, because physicians get you to lives and lives get you to risk pretty quickly. So a lot of the models that are evolving and have been promulgated by CMS and to a lesser degree CMMI are tied to lives associated with physicians and physicians who can get to scale. Volume is key in this equation. You can't work with a doc that has 10 lives. You got to work with a doc that's got 100, 500, 1,000 lives, or get aligned with groups that do that. The second big area, and it's really the only area of opportunity risk I would say that exists for most of us in elder care and senior services and in nursing homes in particular, is our institutional special needs plans, and to a lesser degree, CSNP or chronic special needs plans. So that's about taking direct Medicare risk. An institutional special needs plan is a type of Medicare Advantage plan where you're taking risk for a population that's been institutionalized or an institutional-like special needs plan and managing the utilization of their services. The thing about it is you're building yourself into becoming a health plan or operating like a health plan. They typically require a degree of infrastructure, and for a lot of people do is they go out and partner with someone. They'll partner with a United, a Humana, or an Aetna who's got the back office functionality, who can serve as the TPA in this equation to manage it for you. But it garners you as the owner or participant in the special needs plan greater control over what happens to the beneficiaries who are living in your institution, and as a result, you can manage cost and quality to that. The issue here again is, guess what? Scale. You need to be at a certain scale to make these work. You can't make an iSNP work at 100 lives. You need somewhere in the minimum threshold of about 1,000, much more comfortably at the 2,000 to 2,500 mark in terms of lives. Hence, in various markets around the country, some collaboratives have emerged across, various markets where groups of elder care providers have come together to say, hey, let's participate in a special needs plan. In those conversations, somebody gets to be the driver and other people get to be the participants in that equation. A good friend of mine who I've known for years is always keen to point out that you are either at the table having the conversation or you are on the menu to be discussed. And in this scenario, it is much better for all of us to think about how are we leading? How are we sitting at the table? How can I drive this innovation rather than follow this innovation in my particular market? The third one then is really the evolution of community-based care management models. And these are the ones that are, I would say, struggling to get the most traction around the country. So it's building models to address special or high-risk populations. There's been a lot of interest on various specialty organizations in the last couple of years because they're talking about moving chronic kidney disease and end-stage renal dialysis out of a carve-out into Medicare Advantage plans. So some of the big organizations who are adept at ESRD are building special models to manage that. I'm not recommending that to anyone in this pool because it is incredibly complex and incredibly high risk. But there are other populations, CHF, people at home, people with social determinant related needs. Some of the work that we've done over the course of the last few years with LSA around the constructs like Senior Connect or LSA Senior Connect, they fall into this bucket of community-based care management models. And typically to get in that direction, it's about addressing alternative payment. I'm working with a couple of aging services organizations right now in upstate New York who are working with dominant payers in their market to figure out how are we going to do this for advanced illness management? Individuals who are likely in their last 2 to 4 years of life, who typically are high spenders in the Medicare environment to go to the hospital over and over again. It doesn't really contribute to overall value of quality of life. So how do I manage that person with advanced illness appropriately in the home to deliver the best quality of life possible? And there are payers who are really interested and focused on that population because most Medicare beneficiaries spend the bulk of their Medicare spend in the last 18 months of life. And a lot of that is spent in the hospital, and a lot of times people will say, could you get better quality of life care in the individual's home rather than going to the hospital and over and again? So community-based models, that is, they're designed to serve people in the homes in the community from a care management perspective. They're oftentimes hard to get off the ground, but there are a few good examples that exist around the country about how some people have done this with various populations. My argument, quite frankly, is there's tremendous opportunity for community-based care management right now in the opportunity zone investing from a social capital perspective that a lot of institutions across the country are pursuing. And given the wave of elder advancement or elder growth in our country around this, there are a lot of organizations who are interested in opportunity zone funding as a construct. So, all of that being said, how do we think about the future, given that, there's a lot of unknowns? There are some knowns right now. Home definitely is going to be the preferred place of care. Payment systems are moving directionally in that way. Consumers are moving directionally in that way. How do we think ultimately strategically about that? Well, healthcare has forever changed as a result of COVID. No matter how much we hope everything is going to go back the way it was, everything is going to be different going forward, given the economic stresses, given the way consumers have shifted their preferences, the nature of organizational tiers, fiscal strength of an organization, and your relative market position are all really, really essential considerations to think about as you go into the future. And another colleague of mine really helped develop this model that I've leveraged with a couple of aging services organizations over the last few months as we've walked through strategic planning exercises to think about how we look into the future. And we really break it down into 3 tiers. Tier 1 are organizations who've been relatively unaffected by COVID. And there aren't a lot of organizations that drop into that bucket, but there are people who are usually in our world in the elder care, aging services, senior services space, large, multi-site, over a large geography in a given state or over a multi-state geography who can spread their risk and the challenges across multiple sites. Translated another way, you have a lot of lives. And so multi-site organizations with good geography, they're usually in a better position than, say, the standalone organization. The biggest threatened element in this environment is the standalone family-owned private for-profit nursing home, no question, because they don't have the resource pool to tie into that a multi-site organization does to spread risk and address change, okay? Tier 2 organizations are probably what I consider to be about 35% of the aging services and elder care world. And it's organizations are going to be moderately affected. So my census in the nursing home went down. That impacted my overall organizational bottom line. because my historic financial model for the whole entity is tied up into fee-for-service volume coming through the nursing home. And or the same way, if I'm a CCRC in that environment, my organizational overall model is tied to reoccupancies. So entrance fee revenue coming in, I use that reoc revenue to offset my operating margin because it runs at about 102 to 104%, which is the industry standard. And as a result, people aren't moving or people aren't investing in that space. And we've got a minor variation of what happened in 2008 through about 2013 when the economy tanked and nobody could sell their home and move into a CCRC. They've got an opportunity to rebuild with well-executed strategy and remain viable as an independent organization. And then there's tier 3. They're the people whose volume has completely fallen off the face of the earth. This is physician practices, it's hospitals, it's nursing homes, it's elder care organizations. Everybody in one form. There are tier 3 organizations across every sector that really don't have a lot of choices. They're going to be forever and permanently damaged, and they might be an attractive acquisition target. And so for a lot of these people, they need to figure out what their next step is going to be in this environment. So when we start looking at this, regardless of how you're impacted, whether you're tier 1, tier 2, or 3, you got to think about how you're going to develop scale, okay, whether that's through consolidation or merger or acquisition and delivering services more remotely. So that's what we mean by that is how do I get more into the home? So how do I get around or outside of myself if I'm not in that space? And then ultimately, rising unemployment and COVID is going to drive reimbursement further to capitation and two-sided risk, which means expectations of quality and performance are going to move downhill or downstream towards us. So as more people take capitation and more people are interested in capitation, and I'll tell you why. In a fee-for-service environment, and that's 75% of the hospitals in this country, when their elective volume dropped off about a year ago at this time and stood in the tank until about July, where it ticked up a little bit, but it's been generally pretty bad for the last year. When you are dependent on volume as the driver in your financial engine, COVID is a nightmare because you are counting on people coming to the hospital. We're counting on people coming to the nursing home over and over and over again. In a capitated environment, you're getting paid no matter what. If you've got 1,000 lives, you're getting paid for every single one of those lives every month via PMPM. And if they're not going to the hospital, which is the single biggest spend in almost any elder beneficiary over the course of the last year, guess what? You've made so much money now because you're getting the capitated payments, your medical loss ratios are now a problem for you. You've got to figure out how to discount money back to people. So people who are forward-looking and forward-thinking have figured out capitation is a much better play in the long run than fee-for-service or volume-based thinking is any day of the week. So for them to manage capitated lives effectively, they're going to push down on everyone else to help them manage cost and quality outcomes. So I'm going to go all the way back to what I said 30 minutes ago. If you focus on nothing else, focus on quality, because quality is what's going to make the difference for you going into the future. Regardless of what happens in any of these environments, quality has to be a central tenet in your thinking. So providers are increasingly going to seek financial certainty tied to capitation, tied to value-based, tied to risk. I think, quite frankly, we're going to see accelerated thinking around institutional and chronic special needs plan in the elder care space in the next 2 to 3 years. I think PACE programs are poised to grow tremendously across the country, either individually or in joint venture relationships. Hospitals and health systems, I never thought in a million years would want to talk about PACE, are talking about PACE as an essential component of a value-based strategy for them going into the future. So that all said, more and more, the end game is the value-based healthcare enterprise. So how do I move into that space, and where do aging services or senior services organizations land in the space? So when I start to illustrate that and what that potentially looks like for organizations, it really comes down to these 3 things. If you're a tier 1 provider, if you've got you're a large regional provider or a multi-site organization with a big geographic footprint, you've got formal arrangements with providers or you own them across the continuum care, you're in a good financial position, you're familiar with or evolving towards value-based and risk-sharing payment, now's the opportunity to hedge your bets, move further into risk, partner around technologies, deliver more telehealth or virtual capabilities, delivering into the home, and figure out how I grow. Because in this environment, the bigger you get, the more lives you get, the more risk you can ultimately spread across. At the far end of that equation, that is tier 3 providers, standalone nursing home organization, limited presence in the local market, you do one thing or maybe 2 things, you don't really have extensions across the continuum of care, you don't have a lot of cash on hand, you're in a fee-for-service business, it's a lot of Medicaid tied up to it, you're looking for 2 things. You're looking for a partner, you're looking for a savior, who's going to come along and help you in that environment. Because at the end of the day, and we all know this because we all live in a not-for-profit world, no margin, no mission. At the end of the day, the reality is far too many mergers among organizations happen not because they were strategically planned or well organized or executed. There are a handful of those that do, but most of them ultimately happen because I can't cover payroll the next cycle. So it's a forced merger. It's a forced relationship. Your financial hand is played. And in this environment, there are potentially going to be a lot of people looking for partnership. I think a lot of people drop in the middle. It's the community-based organization with some degree of scale. You've got some degree of market presence, but you really still haven't either grown vertically or horizontally. You've got some degree of financial position that you might be able to leverage, but what you're really looking for there is capital partners. Can I hitch my wagon to a tier 1 provider? If I pick up a bunch of tier 3 providers because I think that scale, chain's only as strong as its weakest link. So you got to be selective about where you land ultimately in that environment. So now is not the time to do this. And that said, sticking your hand in the sand and hoping everything's going to get better in the next 12 months, bad idea. Hoping it's going to get any better in the next 24 months. No, now's the time to pause for a moment, look above everything and say, where am I going? Where do we need to go? What do we need to be thinking about organizationally? So, Charlotte, I saw you waving at me.
Yes, I think there's some questions. Alicia, do you want to take some of the questions? I think Judy Buddy had a question or two.
Yeah, Judy, are you still on? Judy, are you still on? We'd love to hear your question. You had a couple in the chat box.
Yes, I'm still on. Hi, Andy.
Hello.
You always provide a tremendous amount of knowledge. I love the pace at which you speak so we can keep up. But my big question is, you talk a lot about be the quality provider. And for me, it's always been difficult to really understand who's defining quality and what is quality. Some people define quality as length of stay, cost of care. Other people are looking at specific CMS type quality indicators. Yep. So what is quality?
Well, that's a great question, and I'll tell you what I'll tell you what we invariably tell people. It depends, and what I mean by that is it's situational. It's very, very situational. So that's where you need to understand how say, for instance, the payers define quality, how the hospitals and a health system in a market define quality. There are a lot of people, unfortunately, who want to define quality for they want to put it all in one bucket, and they want to say, we're going to use CMS star ratings, and that's how we're going to define quality. I think that's crap, and I tell people that all the time. That's not a definition of quality. That's a measurement stick that, quite frankly, has some really flawed elements in it. So in every single one of those conversations, and this is all about relationship management, and I'll kind of go back to when I was working in the hospital years and years ago. We were just looking at home movies last night, and Melissa was pregnant with Jack, our number 2 child, and I was at lunch with a friend of mine in the cafeteria, and he said, hey, you're about to become the parent of a second child. Do you want some advice? And I said, yeah. And he said, take everything you know about what motivates and how you manage your first child and forget about it because it's completely meaningless with the second child. And he was absolutely right. And then we had a third child, and I was completely lost. The reality is that payers and partner relationships are exactly the same. What motivates one hospital, or what's the definition of quality for one hospital or one partner, is something totally different for another partner organization. And there have been very few markets across the country where people have really thought about consolidating those definitions of quality to make it easy for everyone. Boston is one great example 10 years ago who defined across the 5 health system a common scorecard or expectations of quality for provider organizations in their market. So you knew what they were. It was great. It was groundbreaking. But very few markets have done that. So my advice to people always in that scenario is you got to talk to them individually. You got to ask them that point question. How are you guys defining quality? Is it my cost side? Is it my utilization side? Is it just readmissions? What is it? You're going to find some common threads. I mean, for a lot of people, it's going to be cost. It's going to be readmissions. There are going to be some things that are common and you can gravitate towards that. But it's different for every organization. And I'm sorry to not be able to say, what is the easy definition of quality? It varies so much by payer and market.
Well, I think your point really is the person who's you're purchasing or that's purchasing from you is defining quality. And we have to find out what that answer is.
Yep.
And my second question is, I absolutely appreciate all the focus on home care, but it's not an efficient workforce delivery method of care. And so where are all the people going to come from that are going to deliver this home care? Or is that going to be a limiting force on the ability to expand home care, or do you see that technology will grow much more to supplement that? So I'm curious your response to that.
It's really it's the balance of a couple of things. There's no question, workforce is the issue across the board in healthcare, whether it's in our world, in elder care world, or senior service world. What most people will tell you, and I agree to it up to a certain point, is that there are a lot of things historically that you had to have a home health aide in the home to monitor a person. There are always going to be some things where literally we're never going to get away from touching other human beings. That's central to our work. It's what we do. But the expectation here is that more and more technology as a tool to leverage, to monitor and manage is central to that. I would say that the biggest deficit that people have is no one's got good line of sight to what happens in the home. And what I mean by that is, and also in the nursing home, when a person leaves the hospital and go to the nursing home, the only time a nursing home or an ACO or a payer understands what happened to that patient is when they're looking at claims reconciliation 2 months or 3 months or a quarter and a half down the road, and then they're trying to go back and fix it. There are really, really radically evolving and improving technologies that provide better insight to what's happening in those spaces in real time. And also are providing increasing degrees of predictive modeling about what's going to happen to that individual. So technology is going to play a central role. There's no question about that. And not only is it just the technology, it is a care coordinator or a home health aide sitting at a desk, looking at Zoom visually and being able to touch base with all of those individuals to say, how you doing today? You know, how you doing today, Judy? What's going on? Did you step on the scale? Have you taken your medication? Do you have any questions for me? And with part of the generation that, you know, is aging out now, there's some hesitancy around that technology. For the generations that are stepping into the space and to come behind it, you know, we're all walking around with one of these anymore. My dad, who's 82, has one of these and is about as good as my 19-year-old is. So, you know, the nature of how you're going to be able to use technology to follow and to touch people virtually is really undergoing tremendous change.
Thank you.
Sure.
Wonderful. I know we're coming up to 2 o'clock, but other questions, just take yourself off mute. We've got definitely workforce was a recurring theme in the chat box in terms of that home and community-based piece. Other questions from folks? Looking to see. Wonderful. All right. Well, thank you very much, Andy, for all of your work. And as we've hit the 2 o'clock, I like how Judy said it's fast-paced and a lot to absorb. As Emily put in the chat box, we'll have the recording available as well as the a copy of the presentation to share, and we'll be sending that out to the folks that registered. And look forward to seeing you at further Strength and Service series. So thanks everyone for your time this afternoon. Really appreciate it. So thank you, Andy.
Thank you, everyone. Have a great Wednesday. Bye-bye.